Good evening, dear students. Welcome to you from Sri Rama Hospital, Jagaipet. Today we are going to start a new topic, that is the disease of the urinary tract. Urinary tract can be divided into upper and lower urinary tract. The upper urinary tract consists of the kidneys and ureters. Both of these things are situated in the retroperitoneal region. The lower urinary tract means it is composed of the bladder, the prostate, and urethra. In females, it is bladder and urethra only. The relations of the urinary organs. This is the posterior parietal peritoneum. The urinary organs are situated in the retroperitoneal region. The kidneys, the ureters, and the bladder are all extraperitoneal. So once you remove the peritoneum, you can see these structures well. Kidneys are situated on either side. They are of bean shape, and they have the renal artery and renal vein, and ureter comes out. The ureter comes out and crosses the common iliac artery at this division. It enters the pelvis and then it opens into the bladder on the posterior wall. First of all, let us study about the symptoms of the urinary tract. Pain, frequency, and hematuria are the three cardinal symptoms of the urinary tract. Apart from these things, there are many other symptoms of the urinary tract. So before we go to the discussion of the various diseases of the urinary tract, first of all, let us study about the symptomatology, how they manifest, and how to interpret these symptoms to the urinary organ diseases. Pain. The site and character of pain varies from organ to organ. Renal pain. That means pain generated from kidneys. The pain starts from the loin and radiates to the front of the abdominal wall. It is mostly felt in the back. It is continuous without bouts of colic, dull aching in nature. The cause of renal pain is due to stretching of the renal capsule caused by obstruction of the pelvic junction or inflammation of the renal parenchyma. So the cause of pain in the kidneys is because of stretching of its capsule. So whenever its capsule is stretched, there will be pain. So how the capsule gets stretched? Whenever the pelvic calcium system in the kidneys, they get dilated. that produces stretching of the renal capsule and produces pain. Similarly, if there is any inflammation of the renal parenchyma, there will be swollen kidney that also will cause stretching of the renal capsule producing the pain. So this pain is because of stretch. So it is not colicky. Colicky means intermittent gripping pain. But here it is dull ache or severe continuous pain. That is why this pain should be called as only renal pain. It should not be called as renal colic. Some people they call it as renal colic. That is incorrect. Colic means it must be intermittent, gripping, severe pain. It will be bouts. So there will be pain for about 1 or 2 minutes. Then pain subsides. Then again repeats after 2 minutes. So such recurrent bouts of severe spasmodic or gripping pain is called the colicky pain. So renal pain is not a colicky pain. It is a continuous stretching pain. So that is why it should be called as renal pain. So the pain is present. So whenever you ask the patient, where is the pain? So the patient will show the pain like this. He will keep the thumb at the back and the index finger or middle finger pointing to the hypochondrium. So this is how the patient with renal pain manifests with the pain. So it is the pain in the renal angle to the front of the hypochondric region. What is renal angle? What is renal angle? Yes, what is renal angle? Are you able to hear me? Okay, don't know. Oh, that's fine. If you look at the back, now when you look at the back, the spinal column will be in the middle. So you will see the spinous process. And you will notice erector spinae on either side. Erector spinae muscles. Then from the side of the erector spinae muscle, you will notice the ribs that comes out. So this is the 11th rib, this is the 12th rib. That is called floating ribs. So on either side, there will be 12th rib and the 11th rib. So the junction between the 12th rib and lateral border of the erector spinae muscle is called the renal angle. This is called the renal angle. So usually the symptomatology of the kidney will be pointing towards the renal angle. So the patient keeps his thumb towards the renal angle and fingers will be kept onto the anterabdominal wall like this. So the renal pain means it will be coming from the renal angle to the front of the abdomen. So that is renal pain. Then ureteric pain. Ureter is made of, it is a tube, it is a tubular structure having smooth muscle in its wall. If there is an obstruction in the ureter, then this muscle will undergo vigorous peristaltic activity, just like the intestines. That is why the ureteric pain is always a colicky pain. So it is called as ureteric colic. So the ureteric pain will be radiating from the loin to the groin. Upper ureter pain will be radiating to the groin. The lower ureter pain, that means if the pain is there originating from the lower half of the ureter, then the pain will radiate to the scrotum, perineum, and medial aspect of the thigh along the course of the genitofemoral nerve. Actually, the pain of the ureter radiates along the genitofemoral nerve. So wherever the distribution of genitofemoral nerve is there, so that part will have the severe colicky pain. So genitofemoral nerve divides into genital branch and femoral branch. The genital branch supplies the cremaster muscle, and then it supplies the scrotum. The femoral branch goes into the thigh and supplies the upper part of the medial side of the thigh. So whenever the ureter is spastic, then pain will be felt along the course of the genitofemoral nerve, that is from the loin to groin, and the pain will be radiating to the scrotum as well as to the medial side of the upper part of the thigh. It is a severe spasmodic pain. Actually, the patients with ureteric colic will suffer from such a severe pain that they will not allow you to even sit. So they will be growling, and then the patient's attendants also will be very much worried to see that patient in pain. They will have such severe colicky pain. So the renal pain starts at the renal angle. This is the erector spinae muscle. This is the 12th rib. This is the renal angle. So from here to the anterior abdominal wall up to here. So that will be the characteristic feature of the renal pain. The ureteric pain will be starting at the same point, but it comes down like this and radiates to the scrotum and to the thigh. Bladder pain. The pain is felt in the hypogastric region, aggravated by fullness or emptying of the bladder. So bladder pain, the feature is there will be suprapubic pain, and pain will be aggravated when the bladder is completely full or when it is getting emptied. Strangury. It is a type of severe bladder pain. Whenever the bladder pain is mainly because of inflammation of the mucosa of the bladder. Strangury is inflammation of the mucosa as well as the muscle coat of the bladder. So the muscle also is very much irritated, inflamed. So because this muscle is very much irritated, even small quantity of urine will provoke the stimulus for micturition, which provokes such an intense feel of micturition that patient runs to the bathroom. But he passes only few ml of urine. And that sense of micturition is also very painful sense of micturition. So strangury means intense painful desire to micturate, often passing few drops of blood-stained urine. So this occurs whenever there is inflammation of the bladder muscle. The cause of the pain in the bladder is mostly due to inflammation. This inflammation can be due to calculus or due to a bacterial or microbial infection. Sometimes it can be due to carcinoma of the bladder and carcinoma in situ of the bladder. These things also will produce bladder pain. That is why whenever a patient complains of bladder pain and you think it is an infective condition, you do ultrasound scan and then you do urine microscope examination and give the treatment. But even after 2 weeks of treatment, if the symptoms are not relieved, means you can make out carcinoma of the bladder in situ only by cystoscopic examination. So the person needs cystoscopic examination. Of course, we will deal with all those investigations now. Pain from bladder trigone. So between the two ureteric orifices and internal urethral meatus, there is a triangular area in the bladder. This triangular area in the posterior of the bladder is called the trigone. Here, the mucosa is smooth and it is slightly elevated. This will produce pain in the hypogastric region with radiation to the tip of the penis. This occurs in trigonitis and stones situated over the trigone. Pain originating from prostate and seminal vesicles. It is felt as heaviness in the perineum with features of burning micturition, low back with radiation to legs, and with pain in the penis. So prostate pain will be because it's situated deeply in the pelvis. So the pain will be there slightly in the hypogastric region, also as very much heaviness in the perineum, with pain shooting to the penis and pain radiant to the back. So that is the feature of the prostatic pain. It is sometimes associated with tenesmus. Tenesmus means intense painful desire to defecate. So just like strangury, tenesmus means patients will have intense painful desire to defecate but passes only little amount of mucus with little amount of stools. This happens if the prostate bulges into the rectum. The cause of prostatic pain, acute or chronic prostatitis. So this acutely inflamed prostate, if it enlarges and bulges into the rectum, the rectal muscle also is irritated. So the patient will get the tenesmus. Pain from seminal vesicles alone, example inflammation, felt in both inguinal regions. Pain from urethra, the pain is felt only during micturition. So while the patient is passing urine, then only patient feels pain. So there is a doubt from one of our colleagues, students, why trigone pain radiates to the penis? Actually, the trigone, the prostatic urethra, and penile urethra. So wherever there is irritation, the pain will be felt at the tip of the penis. This is probably, I don't know the exact cause. It must be the same dermatome must be supplying to the innervation of the trigone area. So the sympathetic nerves which innervates the trigone area have the same dermatomal pattern as the nerve supplier to the tip of the penis. So because of that reason, the pain is felt at the tip of the penis. So that is about regarding the pain. Then frequency of micturition. Normally, a person passes 5 to 8 times per day. So that all depends upon the amount of fluid intake and also the season, whether the fellow is in summer or winter. In winter, because of cold environment, so there will be less amount of sweating and insensible perspiration. So because it's less amount of water is being excreted to the skin, then more water will be excreted to the urine. So patient will pass more number of times during winter. In summer, the reverse happens. So it is between 5 to 8 times per day. If the frequency means if the number of times the patient voids urine is increased, it is called frequency. If that frequency is there only during night, then we call it as nocturnal frequency. Frequency should be differentiated from polyuria. That is diabetes mellitus. In polyuria, also the patient passes more number of times, but he passes each time large quantities of urine. That means when you count the daily output of urine in a patient with diabetes mellitus and in a patient with cystitis. Cystitis is one of the commonest causes of frequency of micturition. So in cystitis, patient will be passing only the normal daily output. That means about 1.5 to 2 liters or 2.5 liters of urine. But he passes about 10 to 15 times per day. In diabetes mellitus, the patient will be passing around 2.5 to 3.5 or 4 liters of urine. So because he is producing more amount of urine, the frequency also will be more in diabetes mellitus. So that is why it is called the polyuria. So whenever a patient comes to you and says that he is passing more number of times, so don't jump into the conclusion whether it is diabetes or frequency. What you must do is you must ask the patient to get the 24-hour urine or to measure the 24-hour urine outputs. If it is with a normal range, 1.5 to 2.5 liters, but more number of times patient is passing urine, you call it as frequency. But if it is quantity is more than 2.5 liters, and patient is passing more number of times, then you call it as polyuria. The polyuria examples being, tell me what are the common causes of polyuria? Of course, I have mentioned diabetes mellitus. Tell me another. Very good. Diabetes insipidus. Next to frequency, the hematuria. Hematuria means heme means blood, urea means urine. So blood in the urine is called hematuria. Normal color of urine is due to urochrome, a pigment produced by renal pelvis. That means urothelium, the transitional epithelium of the urinary tract, produces a pigment. That pigment is responsible for the normal pigmentation. Passage of blood in the urine is called hematuria, and it manifests as red-colored urine. Small quantities of blood in the urine makes the urine appear cloudy. If considerable amount of blood is there in the urine, it appears red and dark. Only if just 1 or 2 drops of urine is there in about 300 ml of urine, then urine is not colored red. It is just seen as cloudy. Hematuria is classified as visible hematuria and non-visible hematuria. Visible hematuria means macroscopically you will find discoloration of the urine as red color. Non-visible means it is detected only under microscopy. So earlier it was called as macroscopic hematuria and microscopic hematuria, but now it is being called as visible and non-visible. Whenever you find the patient complaining of blood is there in the urine, you make sure whether it is blood or the other dark color of the urine also can be mistaken by the patient for the blood. So what are the differential diagnosis for red colored urine? Due to drugs, rifampicin, pyridium, due to ingestion of foodstuffs like beetroot, because beetroot contains a pigment called beta-cyanin, so that stains the urine red. Not only urine, even the stools also will be colored red whenever a patient consumes a lot of quantity of beetroot. Causes of hematuria: general bleeding disorders. In any bleeding condition, either bleeding per rectum, hematemesis, epistaxis, hematuria, you must first consider bleeding disorders. Then urinary organs, trauma, infection, commonly tuberculosis, tumor, and calculus. So these are the 4 common causes: trauma, infection, tumor, and calculus. The other causes being infarction of the kidneys, glomerulonephritis, which causes a microscopic hematuria, not a macroscopic hematuria. So these are all the common causes of hematuria. So in the kidney, it can be due to infarction, a trauma to the kidney, then tuberculosis, a calculus. Ureter, stone in the ureter. Then bladder, cystitis, tumors, tuberculosis, bilharziasis, and again vesical calculus. Then Joger's hematuria, also called March hematuria, then urethral neoplasm. Presentation of hematuria: from kidney and dome of the bladder, whole urine is mixed with blood. From bladder, usually bladder neck, the lateral part of the stream is blood stain. That means when the patient is passing urine, the first part comes normal color. Then lateral part will have the blood color. This is called as the terminal hematuria. So terminal hematuria always indicates that the bleeding is from bladder. For the prostate and urethra, the initial stream will be blood stain. The lateral part of the stream is normal color. Then discoloration of urine. So usually discoloration of the urine is mistaken for hematuria. That is why discoloration of urine also you must consider. Discoloration of the urine causes being hematuria. Example, march hematuria. In soldiers after prolonged marching. This is also called jogger's hematuria. So when persons are jogging, they also get hematuria. Or whenever the person does strenuous exercise, just immediately after exercise, the patient will pass blood-stained urine. Any doubts? Okay, then I will ask you a doubt. I ask a question. Why after prolonged marching or after jogging, a person should get hematuria? Why should a person get hematuria following strenuous sports? Why? This goes by various names: march hematuria, sport hematuria, joggers hematuria, like that. Why is it so? Okay, I will tell you. The exact cause is not known. There are various postulations for this. Whenever a person does strenuous exercise, the body compensates more blood to the muscles. So how can it compensate more blood to the muscles? By diverting from other structures. So what are the other structures? From the peripheries, it can't do because muscles are working. So the body will divert the blood from gut and urinary tract, that means kidneys. So the blood from these organs will be diverted to the muscles whenever a person is doing strenuous exercise. So the kidneys become a little bit anoxic. So the anoxic tubules, they will lose their integrity and some of the blood will leak into the tubules because they become anoxic. So that is one postulation. Of course, there are other postulations are also there, but they are all not necessary for you. Then other cause for discoloration of urine is hemoglobinuria. So don't get confused to hematuria. Hematuria means frank blood in the urine is called hematuria. Hemoglobinuria means presence of free hemoglobin in the urine. Hemoglobin is normally present in the RBC. Sometimes what will happen, whenever the RBC lies, that means hemolysis occurs. Free hemoglobin is liberated into the bloodstream. This free hemoglobin is filtered by kidneys and patient will pass this free hemoglobin in the urine. That is also red in color. Then myoglobinuria. So the myoglobin is also another variant which is there in the muscles and it is excreted whenever there is crush injury or injury to the muscles. porphyria. This is an inborn error where porphyrins are not being metabolized in the body, so they are excreted out. Then jaundice urine. It will be high colored urine. Of course, the normal, these are all the abnormal urines, but normally also there can be discoloration of the urine, that is a dark straw color urine, a dark yellow color urine. That is whenever person is dehydrated or when he drinks little amount of water, then urine will be very dark yellow in color. Then pneumaturia. We have already studied about this pneumaturia, so you know about pneumaturia. What is pneumaturia? What is pneumaturia? Experience of air in the urine. So patient will pass froth in the urine. Can you tell me the examples for the pneumaturia? Okay, due to fistula formation. Fistula between what? Okay, good. Intravesical and also rectum and bladder. That means colovesical or proctovesical. Can you tell me an example for intracutaneous fistula? The cause for intracutaneous fistula. Cause for intracutaneous fistula. Sir, not intracutaneous. Cause for intravesical fistula. Intravesical fistula. What the cause for enterovesical and colovesical fistulas? Give me each one example. Can't you say this? We have studied so much in the intestines, disease of the intestines. At least 2 or 3 times we studied about the, yes, very good, Crohn's disease. What is the example for colovesical fistula? Colovesical fistula. It is diverticular disease. It is diverticular disease. Okay, Shruti, you want to see the previous slide? So the discoloration of urine causes being myoglobinuria, porphyria, jaundice, and high colored urine due to dehydration. Then pneumaturia we're discussing. It is passage of frothy urine in the frothy urine. It is due to colovesical or intravesical fistulae. The causes being Crohn's disease or diverticular disease of the colon with chronic diverticulitis producing peridiverticular abscess opening into the bladder. So that produces a colovesical fistula. Then hematospermia. That means if the blood is passed in the semen, then it is called hematospermia, or also called as hemospermia. The causes of this hemospermia being prostate related, that means prostatitis, either acute or chronic, carcinoma of the prostate. So whenever a patient comes to you with hematospermia, that means blood in the semen, then one should do the digital electro examination to evaluate the prostate gland. Then PSA levels must be estimated, that is prostate specific antigen. Then transrectal ultrasound examination has to be done. So these three tests has to be done whenever a patient is having hematospermia, because he may be having a simple disease like tuberculous prostatitis, or he may have a complicated disease like carcinoma of the prostate. So these things can be evaluated by these investigations. For the discoloration of the urine can also be due to drugs like rifampicin, isoniazid, phenazopyridine, the diet like beetroot. For the slide should come before, but came late. Then the other symptom of the urinary tract is difficulty in micturition. The fellow will be having difficulty in passing urine. He has to strain. If he strains and the stream improves, then it is called, that is due to stricture. If it is decreased by straining, then it is due to benign prostatic hypertrophy. Causes of difficulty in micturition: infants due to phimosis, meatal stenosis, urethral valves. That means whenever there is some obstruction to the urine outflow, there will be this problem of difficulty. In adults, it is due to urethritis and stricture urethra. In elderly people and old people, due to benign prostatic hypertrophy, carcinoma of the prostate. And elderly women, due to distal urethral stenosis, uterine prolapse. In young females, it is due to retroverted gravid uterus. All age groups, neurological disturbances. Difficulty in initiation of urination is seen in prostatic hypertrophy or prostatism. This is called as the hesitancy. That means the patient gets a sense of micturition. He goes to the toilet. When he wants to void, the urine won't come. He has to patiently wait for a couple of minutes. So for 2, 3, or 4 minutes if he waits, then gradually the urine stream starts. So this is called hesitancy. So we will discuss about this in detail when we talk about the benign prostatic hypertrophy. Cessation of micturition. So there is no micturition. It may be due to anuria or retention of urine. That means when the kidneys are not generating urine, there will not be no urination. Similarly, kidneys are generating urine, but there is a complete block. So patient is not able to pass out urine. So that is called retention of urine. In retention, there will be painful distension of the lower abdomen. So in retention, because there is an obstruction and urine is not coming out, the bladder tries to push the urine out. So there will be pain in the suprapubic region. And patient will be having desire to micturate, but he cannot micturate. That is called retention. In anuria, that means renal failure, there will be no pain, no distension. So patient has even no sensation of micturition. The causes for retention of urine are same as that for the difficulty in micturition. That means in children and infants, it is due to phimosis and distal urethral stenosis. In young adults, due to stricture of the urethra and urethritis. In old people, due to BPH and carcinoma of the prostate. In young females, due to gravid uterus, retroverted gravid uterus. And in elderly females, due to again distal urethral stenosis or due to the prolapse of the uterus. Urgency. Urge, that means the patient wants to void urine very urgently. That is called urgency. So intense desire to micturate with lack of capacity to withhold urine. Causes: infection in the bladder, prostatitis, benign prostatic hypertrophy, vesical calculus. So in these conditions, the patient will have an urge to micturate. So they cannot wait. They immediately run to the bathroom. Sometimes before they reach the bathroom, they will have passage of urine into their clothes. Then it's called incontinence. Involuntary loss of urine sufficient to cause social or hygienic problem is called incontinence. Straining, muscular effort used to initiate, maintain, and improve the stream of urine. Normally, the urine passes by the bladder contraction. But when the person is using his abdominal muscles also, by contracting the abdominal muscles and by doing Valsalva maneuver to expel the urine, that means that there is some obstruction. That is called straining. So whenever muscular effort is used to drain the urine, it is called straining. Intermittency. Urine stream stops and starts during micturition. So it is not a continuous flow. It stops and starts. Stops for some time, just for a few seconds. Then again it resumes. So that is called intermittency. This is also a future in case of the benign prostatic hypertrophy and the detrusor muscle instability. Post-micturition dribble. Involuntary loss of urine immediately after finishing of urination. You know the bulbocavernous muscle. What is the function of bulbocavernous muscle? What is the function of the bulbocavernous muscle? Do you know bulbocavernous muscle? Do you know bulbocavernous muscle? Yes, it is there in the perineum. Yes. This is the corpus spongiosum of the penis. Up to this is the root. Up to this will be hidden under the scrotum. This particular part is slightly dilated at its proximal end. This is called bulb of the urethra. So this is covered by a muscle on either side. This muscle is called bulbocavernous muscle. It arises from the ischial ramus and then into the median raphe it is inserted. So it surrounds the bulb of the urethra. So what the function? Whenever it is contracted, the bulb gets compressed. So whenever the bulb gets compressed, whatever that is there in the urethra, that gets evacuated. So in the process of micturition, the urine will be secreted, urine will be pumped out by the bladder. So bladder contracts, all the urine it is expelled. So urethra is a very long tube in males. In females, it is a very short tube. So this long tube will be having some urine in itself. So as long as the bladder is pressing, all the urine is going out. Once the bladder contracts, it contracts and evacuates all its contents, then it stops contracting. So there is no more pressure from outside. So that urine that is there in this urethra remains like that. So that few last drops of urine gets expelled by the contraction of this bulbocavernous muscle. So the bulbocavernous muscle function is to expel the last drops of urine and semen. So that is the function. Some people, what they normally, whenever the micturition is there, the bladder contraction will be there. Afterwards, the bulbocavernous contraction is there. All the urine from the urethra is expelled out. So even after the person finishes the micturition, then he will not soil or he will not wet his clothes. But some people, they have the normal micturition. They think that they have completed and they keep on their trouser. Then there will be dribbling of few drops of urine into their pants and that will get moistened. Why? Because there is failure of contraction of this bulbocavernous muscle. So it is failure of bulbar urethra to empty the urine. The next complaint of a patient with the urinary tract symptoms is a lump. The lump may present in the loin, groin, or suprapubic region, depending upon the organ involved. So these are the symptoms of the urinary tract. I hope there is no doubt about this symptomatology. So if you have no doubt, I will go to the next topic, that is the investigations of the urinary tract. Let us start with a simple test like urine examination. If there is a doubt, that is hesitancy and incontinence. Can it be there in the same patient? Yes, it can be there in the same patient. That will be there in a patient with benign prostatic hypertrophy. There will be hesitance as well as there will be some incontinence. So we will discuss about them, how it occurs in the topic of benign prostatic hypertrophy. Okay, investigations of the urinary tract. First, urine analysis. Macroscopic examination of urine. If the urine is cloudy, it can be due to presence of pus, albumin, phosphates, blood in small quantities. So all these things can produce cloudy urine. Why blood in small quantities produce cloudy urine? Because little amount of blood will not cause coloration. For example, for a test tube full of blood, if you just add half drop of blood, half drop, then it is not colored blood colored. It will be only cloudy. That means some haziness will be there in the urine. Unless some amount of blood is there, it can't impart the color. If urine looks milky, then it's called chyluria. Did you ever see chyluria? Hesitancy and incontinence, there are many types. So when we discuss about incontinence, you will understand that. There are altogether 6 types of incontinence. So unless you know about that, I cannot explain why hesitancy and incontinence can be there in a single person. Okay, Manogya? Okay, milky urine. Did you ever see milky urine? That is seen in chyluria. Green colored urine. Injection of large quantities of methylene blue for therapeutic procedures or ingestion of certain Ayurvedic medicines can produce green colored urine. Dark colored urine. It can be due to bleeding from kidneys, porphyria. The future in porphyria is urine is dark in color. When exposed to sunlight, it gets orange coloration. That is porphyria. Then hemoglobinuria also produce dark colored. Already we have discussed about those things. Presence of threads in the urine, that is there in chronic prostatitis. Chronic prostatitis, patient will pass fine threads. So this is not milk, this is chyluria. Urine that is passed by a patient having this symptom called chyluria. That means presence of chyle in the urine. This is normal color of urine, and this is the prostatic threads. You see these white strands in the urine. As these are all the protein plugs, or these are the pus casts. In chronic prostatitis, pus will be extruded from the prostatic glands, and that pus will be there staying in the prostate for few hours, and it gets a cast of the prostatic glandular tube. And when the patient is passing urine, these casts will be washed away into the urine, and patient passes them in the urine. So that is how these are come. These are nothing but the casts of pus generated in the prostatic glands. So this is macroscopic examination, general laboratory examination for specific gravity, albumin and sugar, to evaluate the concentrating ability of the kidneys, glomerular damage, and presence of glycosuria. I hope you all know about specific gravity. What is the normal specific gravity of urine? What is the normal specific gravity of urine? It is a big range is there. When the person has taken a lot of water, the patient will pass dilute urine. So if the patient has taken about some 2 or 3 liters of water, then he starts passing urine. That urine is collected. Then you examine specific gravity. The specific gravity will be around 1.004. Then deprive the patient for overnight. Overnight, you ask him not to drink any water for 12 hours. Then you collect the urine and then examine the specific gravity. That will be 1.020. So 1020. So it will be varying between 1.004 or 5 to 1.020 or 1.030. So concentrated urine will be up to 1.02 and dilute urine will be 1.04. Sorry, 1.004. This is the concentrating and diluting ability of the kidney. A normal kidney has that function. In certain conditions, this diluting capacity and concentrating capacity of the kidney is lost. Then urine will be having a fixed specific gravity. Can you tell me an example? Of course, there is a medical condition. Can you tell me an example where specific gravity of the urine is constant in spite of dilution or in spite of concentration? No, it is not insipidus. No. No, you are right, you are wrong. It occurs in case of chronic pyelonephritis and chronic glomerulonephritis. Whenever there is renal tubular destruction, so there will be leakage of urine which is having the same osmotic tension as that of the plasma. So in that condition, there will be the constant specific gravity. So specific gravity is evaluated to evaluate the concentrating ability of the kidneys. Then albumin and sugar is examined. Then examination for nitrates. Presence of proteins and nitrates indicate infection. Microscope examination for pus cells, RBC, CAS, and crystals. And then voided urine cytology. That means 24-hour urine sample is centrifuged and then examined for malignant cells. Papillomas and papillary carcinomas of the gallbladder will have the exfoliation, and you can see the malignant cells in the urine, in the sediment. Then there is a lab test called BTA bar test, which detects tumor antigen in the urine. Microbiological examination of the urine. The midstream specimen of the urine is examined for bacteriological colony count by culture. What is meant by midstream specimen? Midstream specimen means the patient is asked to is given a bottle. Santi, it is not gallbladder papilloma, it is urinary bladder papilloma. I just said bladder papillomas. Bladder means in the urinary tract, it is urinary bladder. Okay, the midstream specimen means the patient is given a bottle and patient is asked to pass urine in the bottle, collect the urine in the bottle. How he has to collect? He has to leave the first few ml of urine. So he has to pass the urine out. Then he has to collect the urine. Not the last part, not the first part. The middle part has to be correct. This is called midstream specimen. What is the importance of this? The first part will have, the first part is the penile urethra, the terminal part will have some commensal organisms. So if the person starts collecting from the beginning, these commensal organisms also will be collected and they will give a false positive test in the culture test. So the patient must be asked to void few ml of urine so that he will flush away the urethra. Then he has to collect the urine. So that urine will be examined and that will show whether there is any bacteria in that or not by culture test. Presence of more than 1 lakh organisms per ml indicates infection rather than contamination of the urine. Sterile pyuria. That means pyuria means pus in the urine. How do you say pus is there in the urine? By microscope examination shows pus cells. But when you put it for culture, the culture doesn't detect any bacterial growth. So whenever pus cells are there, pus cells means white cells. So whenever white cells are there in the urine, that indicates that there is infection in the urinary tract. So when you try to look for bacteria in the culture, you won't get bacterial culture. Then it is called sterile pyuria. So what are the causes for this? It is the cause being tuberculosis, chlamydial infection. In these two conditions, the ordinary bacterial culture will be sterile. But if you subject this urine for tuberculous bacteria culture, tuberculous bacteria can't be grown in ordinary nutrient media. It has to be grown in a special media. Tuberculous media is different. What is the name of the tuberculous culture media? What is the name of the culture media for growing tuberculous bacillus? Yes, Lowenstein-Jensen's medium. As LJ medium. That's called Lowenstein-Jensen's medium. Okay. So chlamydia also can't be grown in the ordinary culture. That is why you will not be able to see the culture positive in chlamydial infection. So this is called sterile pyuria. Please remember this. This is an important bit. So in short notes, you will get number of times this question. So that is about the urinary examination test. Next to the blood test. Blood counts, serum biochemistry. Blood counts means the total count, the differential count. Then serum biochemistry for the urea, creatinine, electrolytes. So to evaluate for the renal function. Then estimated glomerular filtration rate. Then in calculus disease, serum calcium, uric acid has to be evaluated. Alkaline phosphatase in carcinoma of the prostate. Tumor marker study. PSA, normally 0 to 6.5 nanograms per ml. It is elevated in carcinoma of the prostate, BPH, and prostatitis. It is reduced with drugs like finasteride and dutasteride. So these are the 5-HA blockers. So when they are blocked, then the PSA is reduced. Radiological investigations. They are plain X-ray of the abdomen, contrast X-rays, that is intravenous pyelography, retrograde pyelography, antegrade pyelography, renal angiography, cystogram, erythrogram, then ultrasound scan, CT scan and MRI scan, distal subtraction angiography. So I will deal with all these things. The details of these things I will tell you now. So these are all the important investigations, because kidneys and ureters, they can be evaluated mostly by imaging studies. The clinical examination is not positive in many number of the cases. Unless the disease becomes severe, it can't be examined. It can't give any positive signs on clinical examination. So you must always, most of the times, depend upon the imaging studies and endoscopic studies. So you must know all these studies well. Plain X-ray of the abdomen. So this is called KUB X-ray. What is meant by KUB? K stands for kidneys, U for ureter, B for bladder. So it is an X-ray which comprises the area of the kidneys, ureters, and bladder. This is the basic investigation for the urinary tract. It is taken for evaluating kidney shadows and psoas shadows, to evaluate for radio-opaque densities in the renal, ureteric, bladder, and prostatic areas. This is a simple plain X-ray of the abdomen, or else as you can say it is a normal plain X-ray abdomen. So what do you see here? You are seeing the bony shadows, bony skeleton. That means the vertebral column, the ribs, the pelvic bones, and upper ends of the femur. So these are the bony shadows. So usually your vision will be focused mainly towards the bony shadows. Apart from the bony shadows, you must train your eyes to look for the soft tissue shadows also. Can you see this line? This line. So on either side, this oblique line is there. No, it is not erector spinae. This is the psoas major muscle. The psoas major muscle arises from the transverse process and the sides of the vertebra of the 5 lumbar vertebra. And afterwards, this muscle passes down into the pelvis. It crosses the pecten pubis joins the iliacus muscle and becomes the iliopsoas tendon and inserted into lesser trochanter of the femur. So this oblique line represents the lateral border of psoas major muscle. So this is the psoas major muscle shadow because this is psoas shadow. This is very, very important. Usually in the clinicals, you will be given x-rays and you will be asked to read those x-rays. So most of the times the examiners will ask you, where is this psoas shadow? Show us. So this is the psoas shadow on either side. Next is you focus here on this side, left side. So you can see this shadow. So in the medial side, you are able to see the lateral convex border of the kidney. You can see here up to here. So if there are no gas shadows of the intestines, you can see the renal shadows. These are the renal shadows. Erector spinae doesn't cast a shadow. It is submerged by psoas major shadow. Kidney shadow, it is due to the perinephric fat. It extends from tip of L1 transverse process to L3 or L4. It is situated obliquely parallel to the psoas major muscle. So this is the kidney shadow. It is situated obliquely parallel to the psoas major muscle. Kidney shadow is not observed, means there is lack of perinephric fat. It is a case of perinephric abscess or hematoma. Then absent or tossed kidney. Kidney is absent or tossed, means kidney is not in that position. It has been dropped into the pelvis. So it's called dropped kidney or tossed kidney or improper exposure. So these are the inferences you have to make. Either it is lack of perinephric fat or due to perinephric abscess or hematoma, then absent or tossed kidney or improper exposure. Normally, kidney shadow is situated parallel to the psoas major shadow. Sometimes parallel to the spine, it is not obliquely placed, it is vertically placed. So if it is vertically placed, then you must consider that the patient is having horseshoe kidney. It is a congenital anomaly. If psoas shadow is absent, it can be due to perinephric abscess or hematoma. So that is about soft tissue densities or soft tissue shadows on the plain X-ray, KUB X-ray. Then abnormal radio-opaque densities on the KUB. So the most common cause for the radio-opaque shadows being the urinary stones. Stones in the kidneys, ureters, bladder, urethra, they cast shadows. Then due to gallstones, then calcified lesions in the kidneys and the adrenals, they cast shadow. The calcified lesions being tuberculosis, degenerated or necrosed areas of tumors and hemangiomas, cyst walls, medullary spongy kidney, renal calcinosis, occasionally renal carcinomas. Just I am enumerating all the radio-opaque densities you see on the KUB X-ray. Not only about renal shadows, I am talking about any radio-opaque densities seen on the X-ray KUB. So it can be due to urinary stones, it can be due to gallstones, it can be due to calcified lesions in the kidneys and the adrenals, or due to pancreatic calcifications or calculi. Already we have seen these calculi and calcifications. Then calcified lesions in the lumbar or mesenteric lymph nodes. These also we have seen previously. Then calcified costal cartilages. Normally, costal cartilages, they are made of cartilage. Cartilage is not visible on X-rays. But due to old age, the cartilage may get calcified. Then they will be visible on the X-ray. Then calcified phlebolytes. Flebo means vein. Lith means stone. So stones in the veins. So how can they occur? That means the person is sedentary, not walking, just lying in the bed like that for many months. What will happen? The blood in the veins, they get stagnated, and especially in the lumbar region, the veins, they get thrombosed, and the thrombosed veins get organized and they get calcified. So those are called as the phlebolytes. So they are seen mostly in the old people. Then foreign bodies in the alimentary tract like iron containing formulations or lead balls. Chip fractures are the transverse process of the lumbar vertebra. So these are all the examples for radiopaque densities in KUB X-ray. So whenever you are shown a X-ray in the Vivavos, if there is a radiopaque density, you must think all those things as possibilities. Out of all those things, the common things to be remembered are the renal calculi, or the urinary calculi, then gallstones. These two are the important things. Apart from these things, if you are very good in the examination, the examiner may ask you, what are the other causes for radiopaque densities? Then you will be able to tell all these things. I will show you some examples here. So these are multiple radiopaque densities you are seeing, and on this side, you can see a calculus with multiple branches coming out. So this is called staghorn calculus. Stag means something like a deer. Its horn will be having a lot of branches. In similar way, there will be branches coming out from this stone like this. This is called staghorn calculus. You can see here a radiopaque density. So where from this radiopaque density has come? It can be due to gallstone, it can be due to renal stone, or it can be due to phlebolith. Points for identification of urinary calculi. Renal stones are oval or staghorn shape and are present in the renal area. In lateral view, renal stones cast shadow on the vertebral body, while gallstones cast shadow in front of the vertebral body. So this point already we learned in gallstone disease. So you can see here two stones or two radiopaque densities. One is circular one, the other is oval one. This oval one is longitudinally oval, situated between the tips of the transverse process. That means the ureter runs along the tips of the transverse process. So this is in the line of the ureter. This we can consider this as a ureteric stone, and this round one can be considered as a stone situated in the kidneys, or it may be a gallstone. So how to differentiate? Take a lateral view. And here you can see multiple stones in the right kidney and staghorn calculus in the left kidney. So this is how you differentiate. A kidney shadow will throw a shadow on the vertebral bodies. Gallstones will throw a shadow in front of the vertebral body. Ureteric stones lie along the line of the ureter. That means ureter passes over the tips of the transverse process to sacroiliac joint, from there to the scale spine to the pubic tubercle. Bladder stones are central and suprapubic in position and are usually oval or round in shape. You can see here the bladder calculus. It is round, situated suprapubically. Prostatic stones cast a shadow just below or above the symphysis pubis. You can see here in this X-ray, where is the radiopaque density? Can you make out the radiopaque density in the second film? If you can see it, please tell me, where is it? Yes, very good, Manogya. It is situated over the pubic symphysis region. So that is a prostatic stone. Here you can see. This is vesical calculus, a rounded one situated in the suprapubic region. This is again a rounded stone. Here also a big vesical calculus. There is about the plain X-ray abdomen. Plain X-ray abdomen is mainly to reveal radio-opaque densities. 80% of the urinary calculi are radio-opaque. That is why most of the renal calculi can be visualized on the plain X-ray of the abdomen. Then intravenous pyelography. Intravenous pyelography. Pyelo means pelvis of the kidney. Graphy, that means you can see it. It is a graph to depict the image of the pyelo, that means pelvis of the kidney. So this is achieved by giving some intravenous injection. That is what is called as the intravenous pyelography. Shanti wants to see the previous picture. Yes. This is a large bladder calculus. What you are seeing here is the outer shell is showing as the white layer. The inner shell is not seen. Inner part is seen as black only. That means it is a radiolucent stone, a large radiolucent stone with outer coating of calcium phosphate. Just now I said 80% of the stones are radio opaque, 20% are radiolucent. So this belongs to a radiolucent stone, large stone, and this is being coated by calcium phosphate. Intravenous pyelography. In the plain X-ray abdomen, what we are seeing only simple renal shadow. That's all. Kidney shadow is seen as a oval shadow there by the side of the psoas muscle. Are able to see the kidney pelvis ureters in plain X-ray abdomen? No, we cannot see it. So how to make them visualize? Because they are soft tissue structures, you are not able to see them. But if you fill them with some radio opaque material, then they will be seen. So that is the principle. Water soluble radio contrast dye called sodium diatrosate or trivideo is injected intravenously, and it goes into the blood and is excreted by the kidneys into the urinary tract. And X-rays are taken during the excretion of the dye by the kidneys. It is an anatomical and functional investigation of the urinary tract. Precautions, it should be avoided in the following conditions. History of allergic disorders, because this is made of iodine. Some people are hypersensitive for iodine. So that is why initially before giving this intravenous pyelography radio iodine contrast injection to the patient, you must always exclude the allergic disorders. So inquire about family history of idiosyncrasy to iodine drugs also. Pregnant women should not be given intravenous pyelography because you are subjecting the abdomen for multiple X-rays in intravenous pyelography. So when you subject a pregnant woman's uterus for radiography for 5 or 6 times, then the fetus is going to expose it to a radiation injury and radiation sequelae. So pregnant women should be avoided. Not only non-pregnant women, but also in married and fertile women, IVP is not advised 15 days after menstrual period for the fear that patient may be pregnant. Then should be avoided in patients with dehydration and multiple myeloma. You look at these two films. These two are the intravenous pyelography films only. In this film, you are able to see the pelvis, the calyces, the ureters, the bladder very well. But in this, what you are seeing this black shadow here. This another black shadow. So this is nothing but these are the colon shadows. Air in the colon. Of course, colon is not distended, but this is a normal colon showing the air. So a person will be having a lot of air in the intestinal tract. In the colon, there will be air plus fecal matter also will be there. So air will cast a black shadow. So when a lot of air is there in the colon, then the underlying kidneys can't be visualized well. So you can compare these two X-rays. Both of them are IVPs only. You are not able to visualize the kidneys properly here. The pelvis as well as ureters are not seen well. Of course, bladder is seen well. So you must prepare the patient before sending him for intravenous pyelography. How do you prepare? Why do you prepare? You want to prepare the patient to expel the gas, to expel the fecal matter. So when both of them are evacuated, then you will see a picture like this. So how do you prepare? 2 days of laxative, senna or charcoal tablets, and methyl polysilaxone. Methyl polysilaxone is a gas adsorbent agent. So you give these drugs for 2 days prior to the IVP examination. Then the patient is asked to follow 12 hours fasting. Then in the department, radiology department, first a test dose of 2 to 3 ml of the dye is given intravenously before administering the drug, and all emergency drugs for managing anaphylactic reaction are kept ready. So there are many instances where people died on the X-ray table due to hypersensitivity reaction or anaphylactic reaction to iodine. So you don't think iodine is a very simple drug, what will happen? No, it is very, very dangerous drug. One of my colleagues' father had renal problem, and my colleague went to the radiology department along with his father to get an IVP. He himself administered the radio-opaque contrast medium iodine containing this Conray. He had just given 2 ml of this Conray and patient went into sudden fall of blood pressure, gasping, and within 2 minutes the patient died. So such severe anaphylactic reactions can occur with this iodine. So you must be very, very careful. So emergency drugs must be by your side. You must first give one initial dose, 1 or 2 ml, and then see for 5 minutes whether the patient will get any reaction. If it doesn't get any reaction, then only you must administer the remaining amount. The dye is injected intravenously, not exceeding 300 milligrams, and repeated films are taken at regular intervals depending upon the lesion suspected. So once you give the injection, then you repeatedly take the X-rays. In renal failure, where kidney is not excreting the iodine, IVP is of no use. Observation. At 1 to 3 minutes, nephrogram is seen. What is nephrogram? Now compare both these X-rays. Look for the renal shadows. In the plain X-ray, an indistinct renal shadow is seen here, a very indistinct. But in this X-ray, you can see a good renal shadow. So after giving injection, within 3 minutes, if you take an X-ray, the X-ray will come like this. Why? The dye is being now filtered in the glomerulus. The glomeruli and proximal renal tubules are present in the cortex. So the whole cortex is now containing the iodine. That is why it opacifies the kidneys. So it is not excreted into the tubules. It is not excreted into the calyces. That's why calyces are not seen. Only you are seeing the renal parenchyma is stained because of the uptake by iodine. So this is the enhanced renal shadow. This is called the nephrogram phase. At 5 to 10 minutes, so after 5 to 10 minutes, you take another X-ray. This X-ray will show you 3 major, 7 minor calyces and pelvis of the kidney is seen. The ureter is seen with peristaltic contractions. This is the ureter. The ureter is not having the uniform caliber. It is constricted here. Again, it's constricted here. So you think that there are strictures here. No. These are the normal peristaltic activities. So whenever you see ureter, you can see at least 3 peristaltic activities. So you are seeing one here, another here. If you can go down, you can see third one somewhere here. So these are the peristaltic contractions. Whole of the ureter is seen only in obstruction of the ureter. At 10 to 15 minutes, you can see the bladder as a rounded opacity in the suprapubic region. Then, once you see the bladder, then what you do is you ask the patient to go to the bathroom and void the urine and come back. Then take an X-ray. So because the patient has voided, you see the bladder is like this. That means there is no residual urine, or there is only few ml of residual urine. If the patient voids but still you see a rounded shadow here, that means he has not emptied his bladder completely. So when he is not able to completely empty the bladder, then we call that condition as residual urine. That means some amount of residue is being left behind. So after 30 minutes, post-void film will show no residual urine. In vesico-ureteral reflux, post-voiding film shows lower end of the ureters filled with dye. You can see here, this is a patient with vesico-ureteral reflux. That means bladder urine is regurgitating into the ureters. So you can see ureters have been dilated and become tortuous. So there is retrograde urine from the bladder into the ureters, and after patient voids the urine, you can see the ureters are filled with the red opaque dye here. There is a typical example of vesico-ureteral reflux. Then pathological changes on IVP. So I have shown you the normal. Now I will show you the pathological changes. Anatomical changes regarding site of the kidney, number of kidneys, calyces, deformity of the calyces, filling defects, functional changes. Now you can see here, this is one pelvis, this is another pelvis. So this patient is having double pelvis. You can see here, double kidney. This is one kidney share, this is another kidney. But both of them are present on the same side. So this is duplex kidney. This is called duplex kidney. Now you can see here, this is the pelvis, this is the calyces, and this is the ureter. And you can see a swelling of the ureter, and this part is not filled. So that means this is a filling defect. So there is a filling defect in the middle 1/3 of the ureter. And here you can see a filling defect in the pelvis of the kidney. You can see here the dilated pelvis and calyces. So normally the pelvis will be only of this much size. You can see such large one with dilated calyces. So that is about intravenous pyelography. This antegrade pyelography is not required. Retrograde pyelography. Retrograde means the dye is injected from below to fill the ureters from below upwards. This is retrograde. What you do is you pass a cystoscope, then with the help of the cystoscope you pass ureteric catheters into both the ureters. Then into the ureteric catheter you inject the dye. The dye will fill the ureters and you will see a shadow of the ureters. So this is called retrograde pyelography. So you are not giving through blood. You are directly injecting the dye into the ureters with the help of a cystoscope. This is called retrograde pyelography. You can see here the cystoscope is there in place and the dye is injected here. You can see this filling the ureters. Where IVP is not able to show the pattern, then you go for this retrograde pyelography. So this is also an example of retrograde pyelography. You can see the ureteric catheters here. This is the pelvis and kidneys of both the ureters. Then cystography, also called as cystourethropy. Radiopaque dye is injected into the bladder and radiographs are taken to visualize the bladder and urethra. So what you do is you directly inject dye into the urethra, or you pass a catheter and inject the dye into the bladder. So this is the catheter and you are pouring the dye into the bladder and you are taking the X-ray of the bladder. And when the patient is asked to void the urine, so you will be given, patient will be given a receptacle and patient is asked to void urine. When the patient is micturating, if you take an X-ray, then it's called cystourethropy. So this is to know the pattern of voiding. This is the bladder and this is the urethra. This is called voiding cystourethrogram. Urethropy, radiopaque dye is injected to the urethra and X-rays are taken to visualize the urethral passages. So here you can see the dye is injected directly in the urethra and you can see this is a normal urethra. Here there is a middle block is there. This is the stricture urethra. Then iotography and selective renal angiography. In renal tumors and cysts, to study the vascular anatomy of the tumor and kidneys. So just like in liver, here also you can pass a catheter into the renal arteries and then take the pictures. So this gives the renal artery, selective renal angiography. In very vascular tumors, therapeutic embolization with gel foam or glue may be done to arrest or block the vessels. MRA or CT angiogram is a non-invasive method to study the vessels of the kidney. Ultrasound scan. Of course, already we studied in detail about the procedure of ultrasound scan. So I will skip those slides. I will pertain myself only to the ultrasound scan of the kidneys. General aspects of ultrasound scan already we have studied. So you can see this is the kidney shadow. This is the kidney. Here is the pelvis of the kidney. and you can see a hyperechoic shadow, and this hyperechoic shadow is giving a shadowing effect. That means it is a renal calculus. Similarly, you can see another renal calculus here with shadowing. So there are multiple renal calculi. The ultrasound scan is done for the kidney to assess the size of the kidney, thickness of the renal parenchyma, and presence of calculi in the pelvis of the kidney. So you can see here, this is the kidney shadow, and this is the pelvis of the kidney. So this black one is the renal cortex. So this is the renal cortex, and this is the hilum containing the calyces and blood vessels. Ultrasound scan of the kidney is done to evaluate space-occupying lesions like tumors and cysts. Then to evaluate for para-aortic lymph nodal masses, bladder. In the bladder, it will be done mainly for the filling defects and residual urine. Prostate for size and echo texture and scrotal masses like testicular lesions. Here you can see a cyst here. This is the renal cortex, this whole kidney, and here you can see a cyst here. You can see here multiple dilated calyces. That means there is obstruction below. So this is an example of hydronephrosis. This is also dilated pelvis with dilated calyces. Here you can see a mass lesion. Here you can see a rounded, smooth, black shadow. That means it is a spherical anechoic lesion. That is renal cyst. There is abdominal ultrasonography. Then there is transrectal ultrasonography, where the ultrasonic probe is passed into the rectum and the prostate is examined. Then in suspected case of carcinoma of the prostate, you can see the prostate both lobes. Here is the prostatic urethra. This is how the procedure is done. This is the probe that is kept into the rectum, and this is the biopsy gun. If you want to take the biopsy, then of course, with the help of this, you pass this into the channel that is there for the biopsy gun by visualizing. So you can guide your biopsy needle into the prostate. So the procedure is transurethral biopsy of the prostate gland. Then CT scan and MRI scan for staging renal and prostatic cancer. Pre-biopsy MRI permits selection of cases for transrectal or transperineal biopsy of the prostate. So if you take the MRI before taking the biopsy of the prostate, you will be able to evaluate whether the transrectal route or transperineal route is ideal for the patient. Isotope scanning. So there are many isotopes that are available in the kidney for scanning. DMS renogram is done to evaluate renal structure and to detect renal scarring. DTB renogram is done for evaluation of PUJ obstruction. Then bone scan is done in case of prostate cancer. Then MAG3 renogram is done for evaluation of upper urinary tract obstruction. PET scanning. Already we discussed about PET scanning in relation to the liver. It is done for detection of metastasis in renal, bladder, and prostatic cancer. Urodynamic studies. This is another investigation for evaluation of the lower urinary tract symptoms and incontinence. So in that particular relevant chapter, we will study more about this urodynamic studies. So these are all the imaging studies, starting from plain X-ray abdomen, intravenous pyelography, then cystogram, cystourethrogram, urethrogram, ultrasound scan. So there is a question or a doubt from Dr. Santi. How will the perinephric fat cast a renal shadow? Wherever fat is there, a soft tissue shadow is seen. If you take an obese person plain X-ray abdomen, the abdomen will be seen as a hazy structure because of lot of fat in the abdominal wall. Perinephric fat will be absent in patients who are very thin and lean, who have malnutrition, or where there is destruction of the perineal fat due to perinephric abscess. So whenever an abscess collects there, the abscess causes destruction of the perinephric fat, and the perinephric fat then don't cast a renal shadow. Okay, now we will come to the endoscopy. We have already seen upper GI endoscopy and colonoscopy in relation to gut structures. Now we will study endoscopy in relation to the urinary organs. The most commonly performed endoscopy procedure here is the cystourethropy. In short, it is called cystoscopy. Then ureteroscopy, ureterorhinoscopy, nephroscopy. These are the three types. Cystourethropy. So in this, it is not like a upper GI endoscopy. Here, two types of scopes are there. One is rigid scope, the other is the fiber optic scope. The commonly performed is the rigid scope. Instruments required are a telescope, light cable, light source, sheets of varying sizes. So this is the armamentarium required for doing cystoscopy. I hope all of you must have seen at least 2 or 3 cases of cystoscopy in the OTs. Did you? Did you see any cystoscopy procedure? No? Okay. Okay then. Okay, then I will show you certain details about cystoscopy. This is called the telescope. This is a long, solid, tubular structure, a rod-like structure. This will have an optical lens here. This will have multiple prisms, and here is the optical lens is there. Here is the objective lens will be there, and a side channel is there. The side channel is for connecting the light source. So this is the rod lens system of the Hopkins. This is the telescope. If you look at this end, so you can see illumination is there. This illumination is coming from a light gate attached to the side. The illumination will be there all around. Central part is for optical bundle. The peripheral part is for light bundle. So this is the telescope to which a flexible light guide is attached. This light guide will transmit the light. This light guide will be connected to a light source. So from this light source, light is emitted, and that light will pass through this light guide, and it passes through this cable and comes through this cable, and here the light guide will be there. So with this light guide, that light will be transmitted up to this point. You can see the illuminated end of the telescope. You see the telescope is illuminated. You can see the light all around. Central part is dark. So the dark part is for the objective lens. Now, telescope alone is not passed into the urethra. It will have a sheath for it to pass. So this is the sheath into which the telescope is inserted, and the whole combination is passed into the urethra. This sheath is having two side channels. These channels are for connecting to the water. That means whenever you pass the scope into the bladder is collapsed, you can't see its walls. You have to distend it. In upper GI endoscopy, you have distended the stomach by inflating with air. But in the case of the bladder, you inflate it with water. So the water is connected here, and water is pumped here. The water goes like this in the sheath and distend the bladder. So you connect sterile water to this side channel. So the telescope with the sheath is passed into the urethra. So the urethra is something like a J-shaped structure. So how a straight rod-like structure can pass into the urethra? That may be the doubt. Initially, every student will get this doubt. Once the parts are completely relaxed, the whole thing can be made straight. So what you do is you pass this up to the end of the bulbous urethra. Once it reaches here, then you will get some hindrance. You can't go straight. So what you do is you depress the handle. So once the tip comes here, you depress the handle. Now the tip will face this end. So once it depresses, it comes like this. And now you will be safe to pass the scope into the prostatic urethra and from there into the bladder. This has many accessories. The cystoscope can have many accessories. This is called the bridge of the cystoscope. So through the bridge, you can pass a ureteric catheter. The ureteric catheter can be passed into the bladder and from there into the ureteric orifices. So this is another instrument. This is called lithotripter. This will have, these teeth will be there, crocodile teeth or alligator teeth. So they are very powerful and strong teeth are there. So what you do is you pass this scope. So this is the telescope. The telescope is passed into this alligator forceps. So once you pass this assembly into the bladder, once you see the stone, the jaws are opened, stone is held, stone is crushed. So this is useful to break small stones in the urinary bladder. Of course, this is a flexible cystoscope. So just like upper GI endoscopy, this cystoscope is also flexible. This can be done in the outpatient itself for cystoscopy. So this is flexible cystoscopy. Procedure of cystoscopy under local anesthesia. That means local anesthetic jelly injected into the urethra after 5 minutes. Cystoscope is passed along with the sheath after connecting it to the light source and water source into the penile urethra, membranous urethra, prostatic urethra, and then into the bladder under vision. After entering the bladder, contents of the bladder are emptied, and then the bladder is filled with saline and its interior is visualized. During reticuloscope, the urethra is visualized in detail. So these are some of the normal cystoscopic appearances. So this is the bulbar urethra. So this is the urethral opening. This is at the level of the external sphincter. This is in the prostate. You can see the prostate lobes. These are the lateral lobes. This is the vermontanum. This is the normal bladder. You can see fine blood vessels coursing on the wall of the bladder. And you can see here the ureteric orifice. Sorry, this is the ureteric orifice. Diagnostic uses to diagnose strictures of the urethra, neoplasms in the urethra, urethral calicles, urethral valves, urethral diverticulum. Then prostate for evaluation of BPH, chronic prostatitis, bladder neck hypertrophy, or Marian's disease. Then bladder uses for evaluating inflammatory lesions. They may be non-specific or specific inflammations. Then caliculus disease, obstructive uropathy, tumors in the bladder like papillomas and carcinomas, foreign bodies in the bladder, fistulas like VVF, colovesical fistulas. Ureteric orifices, stenosis, altered anatomy of the orifice like Gold-Fold ureter seen with tuberculosis of the ureter. Then impact calculus at UV junction, and neoplasms projecting from the ureteric orifice can also be observed. If ureteric orifice cannot be visualized, indigo carbamide is injected intravenously. It is expected in 5 minutes and shows as purple colored emission from the ureteric orifices. So this is the indigo carbamide. So when you are not able to find the ureteric orifice, because sometimes they will be very small and flush with the bladder mucosa, you can't see it. Then what you do is inject indigo carbamide dye into the intravenously. The dye is excreted in the urine and that stains the urine blue color. So by looking at the blue color, you can identify the ureteric orifice. Then therapeutic uses of the cystoscope to treat the stricture urethra by optical ureterotomy. Then for prostate diseases, you can do transurethral resection of the prostate for BPH and carcinoma of the prostate to relieve the obstruction. Then bladder cystoscopic lithoplexy for calicles. That means calicles can be broken in the bladder. Biopsy and resection of bladder tumors can be done. Injection of sclerogens done for bleeding tumors, bleeding ulcers. Ureteric orifice, if a stone is impacted at the meatus, you can cut. Okay, this is radiation cystitis. This is a bladder calicus. This is the papillary tumor in the bladder. You can see this is transitional carcinoma. Can you see now? Can you see the slides now? Okay, this is radiation cystitis, where you will see erythema of the mucosa with the dilated vessels. Here also you can see. This is the bladder calculus. This is papillary tumor of the bladder. This is the carcinoma of the bladder. Just I am showing some examples. This is another case of frond-like arrangement of the papilla. This is transient cell carcinoma. This is benign prostatic hypertrophy, where you can see the urethra is just like a slit. There is no urethral opening. So this is the vermontanum, which is hypertrophic, and you can see the lateral lobes, which are very much enlarged or hypertrophic. This, of course, this is called the J-shaped maneuver. The scope is passed into the bladder and tip is curved like this. Suppose this is the scope. The scope is passed into the bladder like this. So this is the bladder. This is the scope. So the scope is passed into the bladder, and then afterwards what happens? What you do is you turn the scope like this. The tip is turned. The tip is bent like this. So when the tip is bent like this, what you do, you can see the bottom here. That means the bladder neck can be visualized. So this is called J maneuver. So when you do J maneuver, the bladder neck can be seen. So you can see here the bladder neck with the projecting prostatic lobes. The lateral lobes of the prostate are projected into the bladder. This is called retrograde viewing. Then ureterorhinoscopy. That means it is passing a scope into the ureters through the bladder. It's called ureteroscopy. Diagnostic ages to evaluate stricture calculi in the ureter. Then therapeutic indication, removal of the ureter calculi, managing strictures. This is normal ureter. Here you can see a ureteric stricture. Here you can see a ureter calculus. So this is the ureteroscope passed via the bladder into the ureter. Next, I will show you a small video clip on cystoscopy. Sorry, I'm not able to show you the video. Don't bother. The nephroscopy. A slender telescope is passed through a small incision in the loin into the kidney directly. This is for removal of the renal calculi. This is the nephroscope. This is a nephroscopic image of calculi in the kidney pelvis. The renal function test. More than 70% of the renal function should be lost before renal failure becomes evident clinically. Just like hepatic failure, kidneys have a very compensated mechanism. That is why more than 70% of the renal function should be lost before renal failure becomes evident clinically. The tests are mostly biochemical. There is estimation of blood urea. It is elevated in renal dysfunction. However, false rise may be present with normal renal function. It is increase in protein catabolism. There is an upper GI bleeding, and in conditions of dehydration also it is increased. Hence, the result may be spurious. Estimation of serum creatinine. Creatinine levels are not altered in dehydration and increased protein turnover. Creatinine clearance test is nothing but UV by B. I hope all of you know this equation, where U is the concentration of creatinine in the urine, V is the volume of urine in 24 hours, B is the concentration of creatinine in the blood. So normally it's about 100 to 130 ml per minute. It indicates approximately the glomerular filtration rate. Then radioisotope scanning. Radioisotopes used are the DTPA indications to evaluate the dilated or obstructed tracts and to evaluate the functional capacity of the kidneys. Isotope bone scan to evaluate the secondaries from renal and prostatic carcinoma. So these are the investigations. So I will stop it here. So this is an introductory topic for the urinary tract. Tomorrow we will study about the kidneys. Before going to the kidneys, just we will review acute renal failure. So when the kidneys fail, what will happen, how to recognize it, what are the types, then we will go to the disease of the kidney. Any doubts, please? Okay, if you have no more doubts, I will just close this session. Yes, about anatomy and everything about kidney, we will talk from tomorrow. Yes, I will tell you tomorrow. Okay, thank you very much. Wish you all good night. See you tomorrow at same time.